Hi friends, I am Bijoy Ajayan, 2012 MBBS batch, Government Medical College, Trivandrum. In the last video, we have discussed in details about the functions of the cortex, right? So how do we localize a lesion in the cortex? That was our content in the last video. In this video, I would like to integrate that knowledge of the functions of the cortex with the blood supply of the brain. And since we are always dealing with the patients of stroke, we will start with the stroke in this video. So first of all, what is the definition of a stroke or a cerebrovascular accident? This is the definition that is given in 19th edition of Harrison. Stroke is nothing but it is the abrupt onset of a neurological deficit that is attributable to a focal vascular cause. And the neurological signs and symptoms, they last for more than 24 hours, or the brain infarction can be demonstrated on imaging. See, when there is a reduction in the blood flow to the brain, cerebral ischemia will develop, right? And so this will lead to neurological symptoms, right? And these neurological symptoms will manifest within seconds. Why? Because the neurons, they lack glycogen, right? And so the energy failure in neurons is very rapid. So the neurological symptoms will appear within seconds itself. And if the cessation of the flow, if it lasts for more than few minutes, then this would result in infarction or death of the brain tissue. While when the blood flow is quickly restored, then the brain tissue can recover fully and the patient's symptoms are only transient. And this is called as a transient ischemic attack, right? So what is a transient ischemic attack? That is, all the neurological signs and symptoms, they will resolve within 24 hours without the evidence of brain infarction on brain imaging, right? There is no evidence of brain infarction. It's just only very transient. Usually it lasts for only a few minutes, right? So that is transient ischemic attack. So now we will come to the classification of stroke. Stroke can be classified into arterial as well as venous strokes. Arterial strokes can again be classified into two, that is ischemic as well as hemorrhagic strokes. So ischemic strokes, they account for about 85% of the arterial strokes, while hemorrhagic, they account for 15% of the arterial strokes. Now ischemic itself, we can divide it into two, that is thrombotic as well as embolic, among which the embolic is the common, right? It is 75%. And the thrombotic can again be divided into large vessel as well as small vessel strokes, that is occurring in the large vessels and small vessels, fine. And embolic, we can divide it into artery to artery strokes, that is the source of emboli is an artery, while cardiogenic strokes, that is nothing but the source is from the heart, that is cardiogenic, fine. And then hemorrhagic stroke, we can divide it into two, that is intraparenchymal and extraparenchymal. Extraparenchymal constitutes subarachnoid, epidural, subdural hemorrhages. So we will go into detail of the ischemic stroke. First of all, we will see the classification of what are the differences between the thrombotic, embolic as well as hemorrhagic stroke. So what is the cause of a thrombotic stroke? Thrombotic stroke is due to a clot that forms directly at the site of infarction. It is in fact a chronic occlusion that leads to thrombotic stroke. While embolic stroke is due to an embolus that is coming from another part of the body and obstructing the brain, vessels of the brain, right? While hemorrhagic stroke is due to bleeding. What are the predisposing factors for a thrombotic stroke? Hypertension, diabetes, dyslipidemia, hypercoagulable states. So all these predispose a person to developing the thrombotic stroke. And embolic stroke, what are the predisposing factors? There should be an evidence of source of embolization. That is, the embolic stroke in fact has a bimodal type of age distribution. That is, it occurs in the young as well as in the old. So in the young patients, the common cause of embolization is a structural heart disease, that is atrial septal defect. And in the older patients, arrhythmias are the most common cause, among which atrial fibrillation is the most common cause for an embolic stroke, right? So what happens in atrial fibrillation? The atria is just fibrillating. There is no active contraction of the atria. So as a result, there would be stasis of the blood, and this would lead to clot formation, and this embolus gets detached and it can go into the vessels of the brain, leading to an embolic stroke. Right. And now the hemorrhagic stroke. What are the predisposing factors? Trauma, hypertension, as well as rupture of berry aneurysms. Now, among these three, the embolic stroke is the most abrupt in onset. Right? It has got the most abrupt onset, and the neurological deficit is maximum at the onset, followed by initiation of recovery. Right? While the hemorrhagic stroke, it has got an acute onset and it is rapidly developing as well as progressive. Now, the thrombotic stroke is subacute in onset. It is also called as a stroke in evolution. So the neurological deficit is slowly developing as well as progressive. Now the time. In case of thrombotic stroke, it usually occurs during sleep. That is, the usual time is between 2 to 4 am. During sleep it occurs, while embolic stroke occurs during activity. That is, usually in the morning, 8 to 10 am is the time. And hemorrhagic stroke, usually it occurs in the evening, about 4 to 6 pm and all. So these are the most common time when these strokes occur. Now headache is severe in case of hemorrhagic stroke. Especially in subarachnoid hemorrhage, you can see the patient usually complains of a severe thunderclap headache. Right. So that is the patient would describe it as the worst headache of my life. So that is subarachnoid hemorrhage. So in hemorrhagic stroke, the headache is very severe, while in thrombotic and embolic stroke, the headache is not so common. Now seizures are the maximum in case of embolic stroke. It can occur in hemorrhagic stroke also, but it is uncommon in thrombotic stroke. Now the consciousness, the disturbance of consciousness is severe in case of a hemorrhagic stroke, while it is minor in case of a thrombotic as well as embolic stroke. Now what about the recovery? The recovery is rapid as well as complete in case of an embolic stroke. The recovery is slow. It is, the mortality is less, but morbidity is more in case of an thrombotic stroke. And the recovery is almost incomplete recovery. In hemorrhagic stroke, the mortality is very high. So these are the differences between the thrombotic, embolic as well as the hemorrhagic stroke. So this is a classification of stroke that is given in our Davidson. Stroke, we can classify it into arterial venous, arterial infarct as well as hemorrhage, infarct or ischemic strokes. And then ischemic strokes, again it is classified into, based on the site of lesion, you can classify it into anterior circulation strokes as well as the posterior circulation strokes. Right? Anterior circulation strokes accounts for the 65% and 20% is the posterior circulation strokes. Fine. So in order to understand the anterior and posterior circulation strokes, we would first discuss the blood supply of the brain. Right? So first we would discuss the blood supply, and then we would go to the anterior circulation and the posterior circulation strokes. So now you can see that in this diagram you have the arch of aorta, you have the brachiocephalic trunk that is dividing into the right subclavian artery and the right common carotid artery, then the left common carotid artery that is directly coming from the arch, and you also have the left subclavian artery. So the anterior circulation, it consists of the internal carotid arteries, right? So that is the carotid circulation. Anterior circulation, we also called it as the carotid circulation. So you can see in this diagram, see, this is the arch of aorta, the brachiocephalic trunk as breaking into the right subclavian artery as well as the right common carotid artery. The right common carotid artery, it will now divide into the external carotid artery as well as the internal carotid artery. So internal carotid artery of both sides constitutes the anterior circulation of our brain. So let us see how this happens. See, once again in this diagram, the common carotid artery is dividing into the external carotid as well as the internal carotid artery, right? So the internal carotid artery, it travels up along the neck and it enters the petrous bone of the skull through the carotid canal, and then it travels through the cavernous sinus, and finally it bifurcates into two, that is the anterior cerebral artery and the middle cerebral artery. So I will show you the bifurcation. See, this is the internal carotid artery. It is finally bifurcating into the anterior cerebral artery as well as the middle cerebral artery. Fine. So before this bifurcation, it gives off two important branches. What are they? One is the ophthalmic artery, right? This is the ophthalmic artery. This enters the orbit along with the optic nerve. Remember that the central artery of retina is a branch of ophthalmic artery. And then you have the anterior choroidal artery. Now that travels posteriorly and it supplies the lateral geniculate body. This is the anterior choroidal artery, right? This is the anterior choroidal artery that travels posteriorly and it supplies the lateral geniculate body, the globus pallidus, as well as the posterior half of the internal capsule. Fine. So now we will come to the posterior circulation. So that is the anterior circulation. Now let us see how the posterior circulation is there. So the posterior circulation, it originates from the vertebral artery. See, the vertebral artery, it arises from the first part of the subclavian artery. You can see in this diagram. See, this is the vertebral artery. You have to have a three-dimensional view of this diagram. This is the anterior circulation and this is the posterior circulation. The vertebral artery that is arising from the subclavian artery is the posterior circulation. So the vertebral artery, it arises from the first part of the subclavian artery and then it travels upward to enter the foramen transversorium of the C6 vertebrae, right? Then again it travels upward and once it reaches the atlas vertebrae, that is the C1 vertebrae, it will move out and after emerging from the foramen transversorium of the atlas vertebrae, it would enter the cranial cavity through the foramen magnum. Fine. So the vertebral artery from both sides would enter the cranial cavity and I will show you the rest in this diagram. See, these are the two vertebral arteries, right? So these are the two vertebral arteries, the right and the left vertebral artery. They come and join to form the basilar artery. The two vertebral arteries, they come and join to form the basilar artery, right? And the basilar artery, it finally bifurcates into two arteries, that is the posterior cerebral artery, right? This is the posterior cerebral artery. Fine. So another important branches include, see, the vertebral artery, before they join the basilar artery, they give off a very important branch that is called as the anterior spinal artery that supplies the anterior portion of the spinal cord, right? So that is a very important artery. The anterior spinal artery, that is just before they form the basilar artery, the two vertebral arteries, just before they form the basilar artery, they give off the anterior spinal artery that supplies the anterior portion of the spinal cord. And you know, the basilar, once they form the basilar artery, they have got the pontine branches, right? So these are small branches, these are pontine branches. And another important artery is the anterior inferior cerebellar artery, right? So this is the anterior, from the basilar artery you have the anterior inferior cerebellar artery, and from the basilar artery itself you have the superior cerebellar artery, right? This is the superior cerebellar artery. So anterior inferior cerebellar artery, the superior cerebellar artery, and you have the posterior inferior cerebellar artery, right? It is also called as the PICA, P-I-C-A, posterior inferior cerebellar artery. So this posterior inferior cerebellar artery, in 50% of the individuals, it arises from the vertebral artery, while in the rest 50% it arises from the basilar artery. So that is the significance. Now see, this is the same diagram. I'll show you. The vertebral artery, two vertebral arteries joining to form the basilar artery. You have the posterior inferior cerebellar artery that is arising from the vertebral artery, and you have the anterior spinal artery that is again arising from the vertebral artery, and you have the anterior inferior cerebellar artery and the basilar artery. The pontine branches are there. The superior cerebellar artery is also there, and finally this divides into two, that is the posterior cerebral arteries, right? Finally the basilar artery divides into two, that is the posterior cerebral arteries. This is the posterior circulation of the brain, right? Now you have the internal carotid artery, that is the anterior circulation, which I have talked about earlier, right? So this is the anterior circulation, this part. This is the internal carotid artery that is breaking down into the middle cerebral artery, the anterior cerebral artery. This is the other internal carotid artery that is breaking down into the middle cerebral artery and the anterior cerebral artery, right? So this anterior circulation is connected with this posterior circulation by an important artery that is called as the posterior communicating artery, right? So this is the posterior communicating artery that connects the posterior cerebral artery with the internal carotid artery, right? So that is a very important connection. And the anterior cerebral arteries, the two anterior cerebral arteries are connected by the anterior communicating artery, right? So this is an oblique lateral view where you can see this exactly. That is, you have the internal carotid arteries, right, that is going into the brain, and you have the posterior circulation, the vertebral arteries for continuing and joining to form the basilar artery, and finally it is bifurcating into the posterior cerebral artery. And now the posterior circulation, the blue color, is connected with the anterior circulation through the posterior communicating artery, right? So that is the how the anterior and posterior circulation are related. So you can see now this has formed a circle, right? This circle is called as the circle of Willis. This in fact forms an arterial traffic circle, right? So what is the functional significance of circle of Willis? That is, this provides an excellent collateral circulation such that if one of the major arteries are blocked, there exists an excellent collateral circulation through which the blood can reach the other parts of the brain, right? So that is the significance of circle of Willis. So now we would discuss about the internal capsule, right? So before going into the strokes, we will discuss about the internal capsule. Since we know the major area of localization, the most common region which we localize in hemiplegia is the internal capsule. Most common site is the internal capsule, right? So we need to know about the internal capsule. So internal capsule is nothing but it is a compact bundle of projection fibers that is situated between the thalamus as well as the caudate nucleus medially as well as the lentiform nucleus laterally, right? This consists of ascending as well as descending nerve fibers which connect the cerebral cortex with the brainstem as well as spinal cord. So in this horizontal section you can see the internal capsule. This is the internal capsule, right? So you have the thalamus here, the head of the caudate nucleus as well as the lentiform nucleus. This is the lentiform nucleus. The head of the caudate nucleus, the thalamus. So what is the clinical significance of internal capsule? You know, this area has got high concentration of motor as well as sensory fibers. So even a small lesion would produce widespread paralytic effects on the body, right? In the horizontal section, you can see that the internal capsule, it is a V-shaped structure, right? This is a V-shaped structure. So once again in this diagram, internal capsule, you can see it is a V-shaped structure. So you have the anterior limb, genu, as well as the posterior limb, right? The anterior limb is situated between the head of the caudate nucleus as well as the lentiform nucleus. Then you have the posterior limb that is between the thalamus as well as the lentiform nucleus, and the genu that is situated between the anterior limb as well as the posterior limb. Fine. So then so an internal capsule consists of mainly 5 parts are there, that is anterior limb, genu, posterior limb, as well as you have 2 more, that is the retrolentiform part as well as the sublentiform part. So I will show you the retrolentiform and sublentiform part in this diagram. See, this is the internal capsule, caudate nucleus, thalamus as well as lentiform nucleus, right? So this is the retrolentiform part that consists of the optic radiation, right? Retrolentiform part, that is behind the lentiform nucleus. Fine. And you have the sublentiform part, that is the violet color, right? Sublentiform part, that is beneath the lentiform nucleus, right? So this is the sublentiform part, that is the acoustic radiation. The retrolentiform part is the optic radiation. Fine. So that is shown in this diagram, the optic radiation as well as the acoustic or the auditory radiations, right? So what happens if the internal capsule is affected? The fibers you have in the anterior limb, you have the anterior thalamic radiation, and in the genu you have the corticonuclear as well as the corticospinal fibers for head and neck, while in the posterior limb you have the corticospinal tract fibers, that is for the upper limb, trunk as well as the lower limb, right? And you also have the superior thalamic radiation here. Fine. So what happens if there is a lesion in the internal capsule? What are the typical features? It includes dense hemiplegia, that is since the fibers are highly concentrated here, the hemiplegia would be very severe, right? So there would be dense hemiplegia. The arm as well as the leg would be equally affected in case of an internal capsular lesion, and there would be hemianesthesia as well as homonymous hemianopia. It occurs when the optic radiation is affected, right? So homonymous hemianopia, hemianesthesia would be there, as well as dense hemiplegia. So this is the classical symptoms that would occur in case of an internal capsular lesion. Now let us see the blood supply of the internal capsule, right? So blood supply, the anterior limb is supplied by the medial striate artery of the anterior. It is a branch of anterior cerebral artery, right? Medial striate artery. This artery is also called as the recurrent artery of Hübner, Hübner's artery, right? So that is the recurrent artery of Hübner, or the medial striate artery of the anterior cerebral artery. Along with the middle cerebral artery, the lenticulostriate branches are there. That supplies the anterior limb. Now the genu is supplied by the anterior choroidal artery, which is in turn a branch of the internal carotid artery. And the posterior limb is supplied by the anterior choroidal artery, that is the branch of internal carotid artery, which I have told you before, plus the middle cerebral artery, the lateral striate artery, that is the lenticulostriate branches of the middle cerebral artery is supplying the posterior limb, right? So now we will go on to the anterior circulation strokes. So first of all, the anterior cerebral artery, right? So the color coding here is yellow. So the anterior cerebral artery, it supplies the medial surface, right? The major portion is the medial surface. The medial surface of the cerebral cortex as far as that of the parieto-occipital sulcus. And also it supplies about 1 inch, a strip of about 1 inch wide on the lateral surface, that on the supralateral surface, right? So remember that in case of unilateral blockade of the anterior cerebral artery, it is usually asymptomatic. Why? Because there exists excellent collateral circulation, and due to that there will be no symptoms if it is occluded unilaterally. But what happens if anterior cerebral artery is occluded bilaterally? In case of bilateral occlusion, you know the areas, the cortical areas now, right? In the last video we have discussed about these areas, right? You have the primary motor area as well as the primary somatosensory area, right? So bilateral damage to the primary motor area, that too in the motor homunculus you have the leg area coming here, the leg, feet and the perineum, right? So that is the area that is coming over here like this. It would be extending. You have seen the motor homunculus in the last video, right? So you have the motor leg area. Since the motor leg area is affected, bilaterally it is affected, in both hemispheres it is affected, so we get paraplegia, right? That is involvement, there will be bilateral involvement of the motor leg area, there will be weakness of both the legs, right? So there will be paraplegia as well as loss of cortical sensations. Again, the somatosensory area is also involved, primary somatosensory area. So there would be loss of cortical sensation over the foot and leg, right? And since the paracentral lobule is involved, there would be urinary incontinence for the patient. Fine, the patient would complain of urinary incontinence. And the prefrontal lobe, it is very important. Since the prefrontal lobe is affected, in case of bilateral anterior cerebral artery occlusion, there would be reappearance of the primitive reflexes as well as cognitive and behavioral impairment, right? And along with that, there will be abulia, that is a delay in the motor as well as verbal response, right? So these are all the problems due to the lesion in the prefrontal lobe. So These are the features of anterior cerebral artery occlusion, that is bilateral anterior cerebral artery occlusion, right? There would be paraplegia, there would be loss of cortical sensations, and then the primitive reflexes would reappear, which are already inhibited, right? I have told you in the previous video. So since the prefrontal area is affected, this would result in reappearance of primitive reflexes, and the cognitive and behavioral impairment would be there, and abulia will also be there, that is delay in the motor as well as the verbal response, right? So that is the anterior circulation, that is the anterior cerebral artery. When the anterior cerebral artery is affected, all these symptoms would appear in the patient, right? Now we will go on to the second artery, that is the middle cerebral artery. So you know the internal carotid artery breaks into two, that is the anterior cerebral artery and the middle cerebral artery. So now we will talk about the middle cerebral artery. How does the middle cerebral artery get occluded? So in Harrison it is given that the occlusion of the proximal middle cerebral artery or its major branches is often due to an embolus rather than intracranial atherosclerosis, right? So what they say that the occlusion is mainly due to an embolus. Now the middle cerebral artery we can divide, the middle cerebral artery has got mainly two branches. See, this is the middle cerebral artery. I'll show you once again. See, the internal carotid artery that is dividing into the middle cerebral artery and the anterior cerebral artery. So this is the middle cerebral artery, the proximal segment of the middle cerebral artery. It is called as the M1 segment, right? It is called as the M1 segment. Now the M1 segment or the proximal segment has got deep branches, right? In this here you can see these are the deep penetrating branches. These are called as the lenticulostriate branches of the middle cerebral artery. So you can see this is the horizontal M1 segment. From there the deep penetrating branches, that is the lenticulostriate arteries, arise, and these supply the caudate nucleus, the putamen, the globus pallidus as well as posterior half of the internal capsule, right? So that is the lenticulostriate arteries. Now it has got the middle cerebral artery, it has got deep branches as well as it has also got the cortical branches, right? So in the Sylvian fissure, see this is the Sylvian fissure. In the Sylvian fissure, the middle cerebral artery, it breaks down the cortical branches, right? So it breaks down into two, that is the superior division as well as the inferior division. Fine. So the superior division, it supplies the frontal as well as the superior parietal cortex, while the inferior division that supplies the inferior parietal cortex. This is the inferior division that is supplying the inferior parietal cortex. This is the superior division that is supplying the frontal as well as the superior parietal cortex, right? So remember, middle cerebral artery has got two branches, that is the deep penetrating branches, that is called as the lenticulostriate branches, and the cortical branches, right? So what happens if a middle cerebral artery is occluded at its stem? That means when a middle cerebral artery is occluded at its stem, both the penetrating branches, that is the lenticulostriate arteries as well as cortical branches would be affected, right? So there will be both cortical symptoms as well as symptom related to these. Fine. So since it is supplying the posterior limb of the internal capsule, the lenticulostriate arteries, which are a branch of middle cerebral arteries, since they are supplying the posterior limb of the internal capsule, you will get that symptoms. What are those symptoms? That is contralateral hemiplegia would be there, contralateral hemianesthesia as well as homonymous hemianopia, right? So that is due to the blockade of lenticulostriate arteries. Now since that is when the stem of the MCA is blocked, right? So the blood supply now to the cortical branches is also gone, right? So not only these symptoms, along with that you will also get the cortical symptoms. What are the cortical symptoms? See, this is supplying the superior division and the inferior division, right? So this is supplying the cortex. I'll show you in this diagram. See, it supplies about 2/3 of the supralateral surface of the brain, right? The middle cerebral artery. So the cortical symptoms would be, since the frontal eye field is involved, there would be gaze palsy. That is, the eyes would deviate to the side of lesion. Fine. And if the dominant hemisphere is involved, there would be global aphasia, Gerstmann syndrome and all. And if the non-dominant hemisphere is involved, there would be, as I have told you previously, there would be anosognosia, asomatognosia or hemi-neglect constructional apraxia. So all these are features of the non-dominant hemisphere, right? So these cortical symptoms would also coexist with the symptoms of the internal capsular lesion if the MCA or the middle cerebral artery is occluded at its stem, right? Now what happens if in case of partial MCA syndrome? So that is the complete MCA syndrome. Now there are some partial MCA syndromes where only the branches, only the superior division or the inferior division gets blocked, right? So if the superior division is having an occlusion there, what would happen? That would be the sensory area is supplied by the middle cerebral artery, right? So the sensory area gone, there would be sensory disturbance. Then the motor weakness would be there, as well as the Broca's area involved, there would be motor aphasia. Fine. Now what if the inferior division is involved? It is supplying the vernix area, right? So the vernix aphasia would be there if it is a dominant hemisphere, right? If it is a dominant hemisphere, there would be vernix aphasia, but there will be no weakness. Why? The superior division is intact, only the inferior division is affected, right? So these are all partial MCA syndromes. And if it is the non-dominant hemisphere, there would be, instead of vernix aphasia, there would be hemi-neglect, right? Without weakness, because again the motor area is supplied by the superior division. It is the inferior division that is getting blocked, right? So these are the symptoms of superior division and inferior division blockade. So these are the partial MCA syndromes. Fine. Now, so that is about the middle cerebral artery. Now we have talked about the anterior cerebral artery, the middle cerebral artery. So I have told you the internal carotid artery, it bifurcates into the anterior cerebral artery and the middle cerebral artery. Now I have told you there is another important branch, that is the anterior choroidal artery, that is traveling posteriorly and supplying the posterior limb of the internal capsule, right? So what happens if there is an anterior choroidal artery occlusion? In case of complete syndrome of anterior choroidal artery occlusion, there would be contralateral hemiplegia, hemianesthesia, and homonymous hemianopia, right? That is a classical thing when the internal capsule is involved, right? So now, but since the posterior limb of the internal capsule is being supplied by the penetrating vessels of the proximal middle cerebral artery, that is the lenticulostriate branches, as well as the posterior communicating artery also, and so because it has got an alternate supply, the minimal deficits occur in case of an anterior choroidal artery occlusion, right? And the patient would recover substantially. Fine. So that is the anterior cerebral artery occlusion. Anterior choroidal artery occlusion, right? Now we will come on to the internal carotid artery. So when in case of an occlusion of the internal carotid artery, the clinical picture will vary, right? So the cortex supplied, usually the cortex that is supplied by the middle cerebral artery is the most commonly affected in case of an internal carotid artery lesion, right? So if the circle of Willis is competent, then what would happen? Even this occlusion may undergo unnoticed also, right? Sometimes it can happen like that, because if the circle of Willis is competent enough, the occlusion may undergo unnoticed. Fine. And if the thrombus, if it propagates up along the internal carotid artery and if it occludes the MCA, then what happens? All the symptoms which we have discussed with the middle cerebral artery, all those symptoms would be there, plus an additional symptom would be there. What is that? That is, the patient would develop recurrent transient monoocular blindness. It is also called as amaurosis fugax, right? So that is due to the ophthalmic artery involvement, right? So the patient usually, the patient would describe it as a horizontal shade that is sweeping up or down the field of vision. Fine. And the patient may also complain that in that eye the patient had a blurred vision in that eye, right? So such complaints would be there for the patient due to the transient, that is a transient, the patient develop recurrent transient monoocular blindness due to involvement of the ophthalmic artery, right? So that is called as amaurosis fugax, something that is consistent with the internal carotid artery occlusion. Fine. So we have talked about the internal carotid artery, the anterior choroidal artery, the anterior cerebral artery, the middle cerebral artery, right? So there we come to the end of the anterior circulation strokes. Now we will start with the posterior circulation strokes. Now before that, I would think it would be better that we know about the cranial nerves first, about the details of the cranial nerves, and then we would go into the posterior circulation stroke for a better understanding, right? So we will start with the cranial nerves one by one. So first of all, the olfactory nerve. So in case of olfactory nerve, you can see that the fibers, they are arising from the olfactory epithelium of the nose, and then these fibers, they pass through the cribriform plate. Fine, they are passing through the cribriform plate into the olfactory bulb, right? And from the olfactory bulb, the fibers will project onto the uncus as well as the parahippocampal gyrus, right? So what are the clinical features if there is a lesion? If there is a lesion of the olfactory nerve, there will be anosmia or absence of ability to smell, right? And this usually occurs in case of skull fractures and also in olfactory groove meningiomas and all, right? And there is another syndrome that is called as the Kalman syndrome, that is anosmia plus congenital deficiency of hypothalamic gonadotrophic hormone, that is Kalman's syndrome. So this is also associated with the olfactory nerve. Now there would be hyperosmia, right? This is anosmia, and there would be hyperosmia, that is increased sensitivity to smell. That would be there in case of migraine, Addison's disease, etc. And what is something special about the olfactory nerve? It is the only sensory modality which has no thalamic connection, right? Which has no precortical relay in the thalamus. So that is the importance of the special thing about the olfactory nerve, right? So that is the first cranial nerve. Now the second cranial nerve, that is the optic nerve. You know, the optic nerve is concerned with vision, right? So we will study the visual pathway. This is the left visual field. This is the right visual field. Each visual field, we can divide it into the nasal as well as the temporal fields, right? This is the nasal field. This is the temporal field, right? And this is the nasal retina and this is the temporal retina. The nasal retina, it receives impulses from the temporal field, while the temporal part of the retina receives impulses from the nasal field. Why is it so? Because the lens, just like a camera, it will invert the image, right? This is the reason for this crossing, right? So that is about the visual field, right? So what happens? Let us see. The impulses, you know, this is sensed by the retina and this goes through the optic nerve. Now at the optic chiasm, it decussates. What decussates? The nasal fibers, right? The nasal fibers of both the sides. You can see the nasal fibers of the right eye and the nasal fibers of the left eye, that decussates to the opposite side, while the temporal fibers, they go uncrossed, right? So through the optic nerve, the impulses will travel through the optic nerve at the optic chiasm and then into the lateral geniculate body, right? That through the optic tract, that is the optic tract. This is the optic nerve, optic chiasm, optic tract, and reaching the lateral geniculate body. Now from the lateral geniculate body, the impulses would go into the occipital cortex through the optic radiation. Fine. So this is how the visual impulses, they reach the cortex, the visual occipital cortex, right? So let us see what are the visual field defects. First of all, there is a total loss of vision in one eye, right? This is the total loss of vision in the left eye when there is a lesion of the left optic nerve, right? The left optic nerve is undergone damage, so there is a left eye, in the left eye there is total loss of vision, right? Now the second damage is at the optic chiasm, right? So if there is a compression of the optic chiasm due to, usually you can say in case of pituitary adenoma and all, right, or craniopharyngioma, pituitary adenoma, right, there would be bitemporal hemianopia, that is both the temporal fields of vision would be gone, the nasal field would be intact, right? This is bitemporal hemianopia that is occurring when there is a compression of the optic chiasm. Now what if the optic tract is involved? The left optic tract is involved. You can see there is a right homonymous hemianopia, right? Now from the lateral geniculate body you have the optic radiation. Now if the lower fibers in the temporal lobe, that is the number 4 lesion, right? If the lower fibers in the temporal lobe is affected, you will get an upper right quadrant anopia, right? upper right quadrant anopia if the left lower fibers of the temporal lobe are affected. Fine. And if the upper fibers in the anterior parietal lobe are affected, then you would get a lower right quadrant anopia. Fine. And finally, if the occipital cortex, if there is a lesion of the occipital cortex, you would get a right homonym. If there is left cortex is involved, then you would be getting a right homonymous hemianopia with macular sparing, right? You can see this area of the macula is spared, right? So these are the same thing, right? Right homonymous hemianopia, that is due to optic tract lesion. Upper right quadrant anopia, that is due to lower fibers of the optic radiation in the temporal lobe. Lower right quadrant anopia, that is due to upper fibers of the optic radiation in the anterior part of the parietal lobe. And right homonymous hemianopia with macular sparing, that is when the optic radiation in the occipital lobe is affected or the cortex is affected, right? So why there is macular sparing? Because this condition usually results in case of a posterior cerebral artery occlusion, right? And the macula is spared. The macular region is spared because of the collateral blood supply that comes from the middle cerebral artery, right? So that is the reason for macular sparing. Fine. So this is how you check the visual field of the patient. You have to ask, if you are checking the visual field of the left eye, you have to ask the patient to cover the right eye with his hand. You have to cover your left eye with your left hand, and with your right hand you have to bring the right hand from all the 4 quadrants and check if there is any visual deficit, visual field deficit. Fine. So that is the optic nerve. Now we are coming on to the 3rd, 4th as well as the 6th cranial nerves, that is the oculomotor nerve, the trochlear nerve as well as the abducens nerve. So why do we talk about these 3 nerves, these oculomotor, trochlear and abducens nerves? Always we are talking about it together. Why is that? Because the eye movement is controlled by these muscles. These the muscles that are being innervated by the 3rd, 4th and the 6th cranial nerves, right? So first let us see how the eye movements, how does the eye move, eyeball move, right? So what are the muscles that help in eye movement? See, you have mainly 2 systems of muscles. One is the rectus system and the other is the oblique system, right? So the rectus system consists of 4 recti muscles, right? So what are those? This is the superior rectus muscle. Then you have the inferior rectus muscle, the medial rectus muscle as well as the lateral rectus muscle. These constitute the 4 recti muscles. Fine. So what are the functions of these? The superior rectus helps to look upward, the inferior rectus helps the eyeball to look downward, and the medial rectus helps in adduction of the eye, and the lateral rectus helps in abduction of the eye, right? So the medial rectus helps in adduction, or it brings the eye towards the nose, while the lateral rectus abduction or away from the nose. Fine. So these are the function of the 4 recti muscles. Now there are, so that is the rectus system, and the other system is the oblique muscles, right? You have 2 oblique muscles, that is the superior oblique muscle as well as the inferior oblique muscle, right? So in this diagram you can see this is the superior oblique muscle and this is the inferior oblique muscle, right? So what is the action of superior oblique muscle and inferior oblique muscle? It is just opposite to their names. It is not just like what we call the superior rectus and the inferior rectus. We know the superior rectus, it helps to move upward, inferior rectus downward. But the superior oblique, it helps to look the eye downward, right? Let us see how it is. See, the superior rectus, you can see that it inserts in front of the plane of the eye, right? And so the action is straightforward. So the superior rectus pulls the eyeball upwards and helps to look upward, right? While the superior oblique is inserted behind the eye, that too at an angle, right? So the action is counterintuitive, right? So the superior oblique, when it contracts, actually it pulls the eyeball downward, and it helps to look downward, right? So the superior oblique helps to look downward and the inferior oblique helps to look upward. So this is really important. So now you remember that, keep this in mind. The vertical movements, it is a little more complicated. The vertical movements depend upon the horizontal position of the eye, right? The different muscles for the vertical movement are activated depending upon the horizontal position of the eye, right? So the rectus system is activated once the eye is abducted, while the oblique system is activated when the eye is adducted, right? So let us see this. See, this is a person who is looking to his right. So the right eye, this is the right eye of the person, this is the left eye of the person. The right eye is abducted, the left eye is adducted. The right eye is abducted by the lateral rectus, the left eye is adducted by the medial rectus, right? So that is the horizontal movements. Now we are introducing the vertical movements, right? So the person is now looking right towards up, right? So that is the vertical movement is also integrated. So now what happens? This right eye is abducted position. So in case of abducted position, which system is activated? In case of abducted position, it is the rectus system that is getting activated, right? So it is the superior rectus helps to look upward. In case of this eye, it is the superior rectus acting here, right? And what is the case in this eye? So when the eye is adducted, which system gets activated when the eye is adducted? It is the oblique system that is activated when the eye is adducted, right? So in this eye, that is the left eye, it is in adducted position. So adducted as well as it is looking upwards, right? So this upward movement, this vertical movement is caused by the inferior oblique muscle. As I have told you, the inferior oblique muscle is the muscle that helps to look downward, and superior oblique is the muscle that helps to look upward. Sorry, it is the opposite way. The superior oblique is the muscle that helps to look downward, and the inferior oblique helps to look upward, right? So in this, again, you can see in the right eye, this is the right eye, this is the left eye. The right eye is abducted. In case of abducted, the person wants to look down. So the rectus system is activated, inferior rectus. Now here the eye is adducted, and the person wants to look down. So it is the superior oblique, right? So here the superior oblique is acting. Now this is the, once again we'll just revise it. So this is the right eye of the patient, this is the left eye of the patient. The right eye, to abduct it, you need lateral rectus. In the abducted position, to look upward, superior rectus, downward, inferior rectus, right? Now if this eye is adducted by the medial rectus, to look upward, it is the inferior oblique, right? The oblique have an opposite action. Inferior oblique helps to look upward and superior oblique helps to look downward, right? So that is inferior oblique as well as the superior oblique, right? So superior oblique helps to look downward and inferior oblique helps to look upward, right? So this is the, so that is the right eye. Now the left eye, again, once it is adducted, the inferior oblique helps to look upward, the superior oblique helps to look downward. If it is abducted, it is the superior rectus system is activated, that is superior rectus as well as the inferior rectus are acting. Fine. So I hope most of you know this formula, that is LR6, SO4 and R3. What is it? Nothing. The 6th cranial nerve supplies the lateral rectus. It is the 4th cranial nerve that supplies the superior oblique, SO4, right? Superior oblique. So the superior oblique is supplied by the 4th cranial nerve, that is the trochlear nerve. The lateral rectus, LR6, is supplied by the 6th cranial nerve or the abducens nerve, right? And the rest of the cranial, rest of the muscles are being supplied by the oculomotor nerve, right? So this is the nerve supply of these muscles. This is a mnemonic for remembering the nerve supply of the muscles. The lateral rectus is supplied by the 6th nerve, the superior oblique by the 4th nerve, and rest of the muscles are being supplied by the 3rd nerve, right? So that is about the eye movements and the muscles that help in the eye movements. Now We will start with the oculomotor nerve. Each nerve we will deal, right? So the oculomotor nerve or the third cranial nerve. Fine. So the third cranial nerve has the nucleus in the midbrain, right? You can see here, this is the oculomotor nucleus. So it just passes in the anterior part of the midbrain, right? Passes downwards, and then it is in close relation with the posterior communicating artery. You can see in this diagram. See, the oculomotor nerve passes in close relation with the posterior communicating artery, right? This is the relation. It's a very important relation. So the oculomotor nerve, it passes in close relation with the posterior communicating artery. Then it passes through the lateral wall of the cavernous sinus and enters the superior orbital fissure to supply all the muscles except lateral rectus and superior oblique, right? So the oculomotor nerve R3, it is supplying all the muscles except the LR6 and SO4, that is lateral rectus and the superior oblique. Fine. So, and not only that, it also supplies the levator palpebrae superioris. What does levator palpebrae superioris do? It helps in elevation of the upper eyelid to open the eye, right? So it helps to open the eye. It helps in the elevation of the upper eyelid. That is levator palpebrae superioris. Now, the oculomotor nerve, it has got another parasympathetic supply that comes from the Edinger-Westphal nucleus, right? So the parasympathetic supply comes from the Edinger-Westphal nucleus that forms the periphery of the oculomotor nerve. The parasympathetic fibers are present on the periphery of the oculomotor nerve, right? So this parasympathetic supply helps to constrict the pupil, right? It helps in the pupil. It helps to constrict the pupil, as well as it acts on, through the ciliary muscle. It helps in accommodation also, right? So let us see the pathway that helps in it. See, this is the pupillary light reflex pathway, right? How does this function? This is the left eye, this is the right eye. You are showing light onto the left eye, right? So the impulses would travel through the second cranial nerve, that is the optic nerve, right? Through the optic nerve, this would reach the lateral geniculate body, right? So some fibers, without synapsing at the lateral geniculate body, they branch off into the pretectal nucleus of the midbrain, that is located at the superior colliculus, right? So this is the pretectal nucleus, right? This is the pretectal nucleus. Some of the fibers, they reach the pretectal nucleus. Now the pretectal nucleus, it projects bilaterally, that is onto both sides of the, on the both sides it projects onto the Edinger-Westphal nucleus, right? So from this pretectal nucleus, the neurons would reach the impulse would reach the Edinger-Westphal nucleus on both the sides. Fine. And from the Edinger-Westphal nucleus, the parasympathetic fibers, right? They, through the third cranial nerve, reach the ciliary ganglion, and through the short ciliary nerve, it supplies the constrictor muscles, that is the sphincter pupillae, causing the constriction of the pupil. So once you are showing the light into this eye, that is the left eye, the impulses reaching through the optic nerve, reaching the lateral geniculate body, some fibers branch off, and the impulse would reach the pretectal nucleus. From the pretectal nucleus, it goes to the Edinger-Westphal nucleus on right, as well as on the right side as well as the left side, right? And so from the Edinger-Westphal nucleus of the left side, the impulses would reach the left eye, the sphincter pupillae muscles, that results in constriction of the pupil of the same eye to which the light is shown, which is called as the direct light reflex. Fine. And at the same time, I have told you the pretectal nucleus is projecting onto Edinger-Westphal nucleus of both sides, right? So the right Edinger-Westphal nucleus, the impulses will go to the right eye, and the pupil of the right eye also constricts, and this is called as the consensual light reflex, right? So this is the pupillary light reflex pathway, very important to know. Fine. So not only the parasympathetic supply, it not only supplies the sphincter muscles of the iris, causing the constriction of the pupil, but also it supplies the ciliary muscle, which focuses the lens for accommodation, right? For near vision, the lens should be focused, right? So for accommodation, the ciliary muscle is helping. So the ciliary muscle is also getting the supplied from the third nerve, right, through the parasympathetic fibers. Now, what happens in case of an oculomotor nerve palsy or a third nerve palsy? So, what all will be there? I told you that it is supplying the levator palpebrae superioris, that is responsible for elevating the eyelid, right? So, it is gone. Ptosis will result, drooping of the upper eyelid, ptosis. Then, what happens to the eyeball? Since the lateral rectus and the superior oblique are intact and their function is predominating, right? So, the lateral rectus is going to abduct and superior oblique going to is helping the superior oblique helps to look the eyeball downwards, right? So, you will get a down and out eye, right? So, this is classical of an oculomotor nerve palsy. And of course, since the two eyes are in two directions, you will be having diplopia. The patient would be having diplopia, right? And since the parasympathetic supply is through the oculomotor nerve is affected, the pupil will be dilated, right? Because constrictor pupil, the sphincter pupillae that is supplied through the parasympathetic fibers of the oculomotor nerve is damaged. Then what happens? That pupil will get dilated. It will not constrict. Fine. Then, so dilated pupil will be there. The light reflex would be absent. The pupillary light reflex would be absent. And accommodation, there is paralysis of accommodation, right? Because the ciliary muscle is also not getting its innervation, right? So there would be paralysis of accommodation, that is also called as cycloplegia, right? So this dilated pupil as well as the absence of the light reflex, this you call it as the internal ophthalmoplegia. Fine. Now, this is an important concept to know. See, the oculomotor nerve, if you take the cross section, you can see that the motor fibers are in the center, right? In case of the third cranial nerve, the motor fibers are in the center and parasympathetic fibers are at the periphery. So, the fibers on periphery are first affected by compression, right? For example, I have told you the oculomotor nerve is in close relation with the posterior communicating artery, right? And so, the posterior communicating artery, it presses onto the third, in case of posterior communicating artery, aneurysm, it presses onto the third cranial nerve. So, the fibers on the periphery are getting affected, right? On the periphery are getting affected due to this compression. So, posterior communicating artery aneurysm, or also in case of uncal herniation, right? The uncus can herniate and it can compress the oculomotor nerve. So, in case of uncal herniation also, it is a compressive lesion. In all compressive lesion, the peripheral fibers are affected first, right? Resulting in dilated pupil or mydriasis. Fine. And also there will be loss of light reflex. The parasympathetic fibers are affected. Now, in case of ischemic or diabetic nerve palsy, the motor fibers are first affected. The central fibers in case of a vascular disease, okay, and also in case of diabetes. When there is ischemia or infarction of the nerve, the motor fibers are first affected in such cases. Fine. So that is very important. So in these cases, when the motor fibers are affected, what happens? The sphincter pupillae would be spared, right? Because parasympathetic supply is less affected. So that is about the third cranial nerve. Now another important thing which usually the examiners ask is, what are the different causes of ptosis, right? So the third cranial nerve palsy, Horner syndrome, which we will see in a minute, myasthenia gravis, snake bite, myotonic dystrophy, all these are causes of ptosis. So we will see the Horner syndrome, right? So what is the difference between the third cranial nerve palsy and Horner syndrome? So to understand the Horner syndrome, we need to understand the sympathetic pathway that is responsible for dilating the pupil, right? So this is the sympathetic pathway. Any lesion in the sympathetic pathway would cause ipsilateral Horner syndrome. Fine. So how is the sympathetic pathway? Let us look. You have three neurons. That is, first of all, the first order neuron, right? So the first order neuron, it begins in the hypothalamus, right? So it begins in the hypothalamus. It comes downward without crossing itself. It comes downward and it synapses in the intermediolateral horn of the spinal cord, right, at C8 to T1 level. that is the level where it synapses. Now this is also called as the ciliospinal center of budge, right? So first order neurons from the hypothalamus, they come down without crossing, they synapse at the CA to T1 level of the spinal cord or the ciliospinal center of budge, right? Now from there the second order neurons start, right? Second order neurons, they exit at the T1 level, and at the T1 level they exit, then they will travel along the cervical sympathetics, right? Cervical sympathetics, which are having a close relation with the apex of the lung as well as the subclavian vessels, right? So that is the second order neuron. They exit at T1 and they travel along the cervical sympathetics, cervical sympathetic chain, and they will synapse in the superior cervical ganglion, right? So that is the second order neurons. Now the third order neurons, they start from the superior cervical ganglion, they plexus around the internal carotid artery, and then through the cavernous sinus they enter the orbit as the long ciliary nerve supplying the dilator pupillae. Fine. So this is how the sympathetic pathway is supplying the dilator muscles of the eye, resulting in dilatation of the pupil, right? The sympathetic fibers, they not only supply the dilator pupillae, but they also innervate the smooth muscles of the eyelids, right? The eyelids, the smooth muscles of the eyelids are also innervated. Also they innervate the sweat glands of the forehead as well as the face. The sweat glands of the forehead and the face, the smooth muscles of the eyelids, the dilated pupillae, all these are being innervated by the sympathetics. Alright, so once again, from the hypothalamus to the ciliospinal center of budge, from there at T1 level it exits in close relation with lung and the subclavian vessels, and through the cervical sympathetic chain it synapses in the superior cervical ganglion, and from there in relation with the internal carotid artery it reaches through the cavernous sinus, it reaches the as the long ciliary nerve, it enters the orbit and supplies the pupillary dilator muscle. Fine. So any lesion in this pathway would cause an ipsilateral Horner's syndrome. So what is Horner's syndrome? There are 5 features. One is meiosis. By meiosis, the dilator pupillae, right? The nerves are supposed to supply the dilator pupillae, whose function is to dilate the pupil. That supply is gone. That would result in meiosis or constriction of the pupil. Here you can see, when compared to the right eye, the left eye, the pupil is constricted. That is meiosis. Fine. Then there would be partial ptosis, right? The ptosis is only partial. Why? Because the sympathetic, I have told you, it innervates the smooth muscles of the eyelid. In case of the upper eyelid, you have the superior tarsal muscle or the Muller's muscle, which along with the levator palpebrae superioris helps to elevate the eyelid. It has got a minor function to elevate the eyelid. So damage to this pathway would result in a partial ptosis, right? So that is the difference between oculomotor nerve palsy and Horner syndrome. In Horner syndrome, the ptosis is only partial ptosis, right? And also in case of oculomotor nerve palsy, you will get a down and out eye, dilated pupil, right? Here the pupil is constricted, meiosis, right? So these are the features that differentiate. Now anhidrosis. Why anhidrosis? I have told you, the sympathetic fibers are innervating the sweat glands of the forehead as well as the face, and hence this pathway, if it is affected, there would be absence of sweating on that side, right? There would be absence of sweating. So that is called as anhidrosis. Now there would be apparent enophthalmos. The enophthalmos is not real. What is enophthalmos? Nothing but it is the posterior displacement of the eyeball, right? So the enophthalmos is just apparent. It is not real. Why does there is apparent enophthalmos? You know, the upper eyelid undergoes ptosis, right? Partial ptosis is there. And you know, the lower eyelid, it is pulled up due to paralysis of the smooth muscle that is responsible for retraction of the lower eyelid, right? The lower eyelid has got smooth muscles that is responsible for its retraction. So once this sympathetic supply is gone, this is gone, right? So this lower eyelid will be slightly pulled up. The upper eyelid, due to partial ptosis, again it is down. So you know, actually, so the palpebral fissure, right, will be narrowed. The palpebral fissure will be narrowed, giving an apparent enophthalmos, right? Now there will be absence of ciliospinal reflex. What is ciliospinal reflex? Ciliospinal reflex is nothing but it is the dilatation of the ipsilateral pupil, right? The same sided pupil, ipsilateral pupil will be dilating in response to a pain that is applied on the neck, right? So if you apply a pain onto the neck, the same sided pupil will dilate, right? For example, if you pinch the right side of the neck, the right pupil will dilate, right? So that is cerebrospinal reflex. That would be absent in case of Horner's syndrome. So always remember, Horner syndrome is a very important topic in medicine and surgery as well. So you should know the features of it, that is meiosis, partial ptosis and hydrosis, apparent in ophthalmos, absence of cerebrospinal reflex, right? So what are the causes of Horner syndrome? Let us see. The causes can be divided into three. That is, due to the central lesion, that is first order neurons. If there is a lesion of the first order neuron, if there is a lesion of the second order neuron or third order neurons, it can cause Horner syndrome, right? So if the first order neurons, that is from the hypothalamus to the intermediolateral horns of the spinal cord at the C8 level, if the first order neurons are, so the lesion is there at the first order neurons. What are the causes for a lesion at the first order neurons? One is lateral medullary syndrome, which we would discuss. And brainstem diseases, again sympathetics would be affected, right? And syringomyelia, that is nothing but the central canal is just enlarging, the central canal of the spinal cord, right? So that is syringomyelia, syringobulbia, all these can compress the sympathetics, right? And spinal cord tumors, that is in cervical cord above C8 level, this can also cause Horner syndrome. Now the preganglionic fibers, that is the second order neurons from C8 to the superior cervical ganglion, right? So what are the causes? Pancoast tumor. I have told you the cervical sympathetics, okay, the second order neurons, they are in close relation with the apex of the lung. So a tumor at the apex of the lung, that is Pancoast tumors, would cause Horner syndrome. Then cervical compressive radiculopathy like intervertebral disc prolapse and neck lesions can also cause a Horner syndrome, can also affect the second order neurons. Now, when does the third order neurons affected? In case of cluster headache, internal carotid artery dissection, right? It is in close relation with the internal carotid artery, right? Then nasopharyngeal carcinoma, cavernous sinus lesion, carotid and aortic aneurysm as well as dissection, and in case of diabetic autonomic neuropathy. Fine. So that is about the third nerve as well as the Horner's syndrome. Now we will discuss two named pupillary defects. One is the ARGYLL-Robertson pupil. What is ARGYLL-Robertson pupil? It is nothing but it is a small irregular pupil that is fixed to light, but it constricts on convergence, right? That means if you show light into the eye, there is no direct or consensual light reflex, but the accommodation, right? Once you on convergence, the pupil will be constricted. So this was once considered diagnostic of neurosyphilis. Now the syphilis is gone. Now it is occasionally seen in case of diabetes or multiple sclerosis. So this is ARGYLL-Robertson pupil, right? This is a short form for remembering the ARGYLL-Robertson pupil, ARP, right? That is ARGYLL-Robertson pupil, right? You can remember in this order, that is accommodation reflex is present, pupillary reflex absent, right? So no reaction to light. Once the eyes is converged, there will be constriction of the pupil. So that is ARGYLL-Robertson pupil. Now the relative afferent pupillary defect. What is it due to? It is due to incomplete damage to one optic nerve, right? This has got another name that is also called as the Marcus gun pupil. So this Marcus gun pupil, you can diagnose it by a swinging flashlight test. What is that? Let us see. See, this is the patient who is sitting in front of you, right? So he is having a lesion, his right eye, right optic nerve. There is an incomplete lesion of the right optic nerve. So we can say that the right eye detects only half the light than the left normal eye, right? So what are you doing? You are just showing the light onto the right eye. So there is incomplete optic nerve damage. So the pupillary, since there is only incomplete damage, the pupillary pathway is intact. So there would be a direct reflex as well as a consensual light reflex. The pupil will constrict. Now you are immediately showing the torch to the left eye. Now what happens in the left eye? once you show the torch in the left eye, even more impulses are going, right? When right eye, there is a damage of the optic nerve, slight incomplete damage of the optic nerve. So left eye it is normal. So about, you can say that double the stimulus is going through the left eye. So as a result of this, the constriction will be more compared to case A. That is when you are showing the light in the right eye. So the constriction would be more. You can see this is the normal size of the pupil. Once you are showing the light in the right eye, this is the size, and once you are showing in the left eye, again it is constricting, right? And you have to show it again once. After showing in the left eye, then once again you bring it back to the right eye, right? So what happens? There would be apparent dilatation of both the pupils. Why? Once again the stimulus that is carried through the right optic nerve is weaker, right? So because of that, there will be apparent dilatation. Now this is actually a constricted state because you are showing the light onto the right eye. This is actually a constricted state when compared to the normal. This is a constricted state, right? But when compared to the light shown in the left eye, there will be apparent dilatation of the pupil, right? So this is called as a relative afferent pupillary defect. And anisocoria, that is the pupil will be of equal sizes, right? Unequal sizes not there. There is both the pupils are of equal sizes, right? So anisocoria is never present. So this test is called as a swinging flashlight test. You are immediately swinging the light from one eye to the other eye, right? So that is swinging flashlight test. So that is relative afferent pupillary defect, also called as Marcus gun pupil, and it is seen in case of multiple sclerosis, right? Multiple sclerosis is a demyelinating disease. So now we come on to the fourth nerve, that is the trochlear nerve. So what is something special about the trochlear nerve? The nerve fibers, they decussate. This is the trochlear nerve nucleus, and the nerve fibers, they decussate before leaving the midbrain posteriorly, right? So this is the only cranial nerve that exists through the posterior surface, right? So this is the only cranial nerve that is exiting through the posterior surface. So this exits through the posterior surface of the midbrain. So this encircles the midbrain, and then it passes through the lateral wall of the cavernous sinus, enters the orbit through the superior orbital fissure, and it is supplying which muscle? SO4, right? Fourth nerve, trochlear nerve, supplying the superior oblique muscle, right? And because of this course, right, posterior course, it is often vulnerable to head trauma. Fine. So what are the features? There would be if there is a lesion of the trochlear nerve, there would be extorsion of the eye and weakness of downward gaze. So what is extorsion? See, there are another two important movements, that is extorsion as well as intorsion. The superior oblique muscle helps to intort the eye, right? That is inward rotation is called as intorsion. So superior oblique helps to intort the eye, while the inferior oblique is helping to extort the eye. That is outward rotation is extorsion. So it is a rotationary movement. Fine. So that is the superior oblique helps to intort the eye. The inferior oblique is helping to extort the eye. Once the superior oblique is paralyzed due to damage to the trochlear nerve, what happens? Intorsion is not there. So the eye will extort. Right? So there will be extorsion of the eye as well as weakness of downward gaze. Why? Because the superior oblique, the function is to help the eye to look downward, right? So because of that, there would be weakness of the downward gaze. And there will be vertical diplopia, which increases when the patient is looking down. Fine. Another feature is that there would be head tilting to the opposite side in order to compensate for extortion, right? So this eye is extorted, and so in order to compensate that, the patient would tilt his head to the opposite side of the lesion. So let us see how it is. See, the case A is a normal case, right? So this is a normal person. You have the person, this is the right eye of the person, this is the left eye of the person. Fine. So once the person is turning his head to the left side, what happened? There is a compensatory intorsion of the left eye, as well as there is a compensatory extorsion, that is outward movement of the right eye, right? So the right eye will extort and the left eye is going to intort. That is compensatory process in order to get that proper binocular alignment, right? So you can see this is the proper binocular alignment, right? So in order to get the axis parallel, the person when the person look to his left, what happens? The person is looking to his left, right? There would be compensatory intorsion or inward movement of the left eye, and there would be extorsion of the right eye, right? And in case of a trochlear nerve damage, what happens? You can see the right trochlear nerve is damaged in this person, and hence the right superior oblique is gone. So superior oblique, what is the function? Intorsion, right? So once superior oblique is gone, the eye will extort, right? It is outward rotated. So right eye is outward rotated. So in order to compensate for this, what does the person do? The person will tilt his head to the left side, right? Once he is tilting to the left side, what happens in the left eye? The right eye is paralyzed, okay? The extortory movement is not there. So the intortory movement is not there, right? So in case of the left eye, this will undergo compensatory intorsion, right? So what happens? The axis will be parallel again, that is permitting the binocular alignment. Fine. So this is why the person is tilting the head to the opposite side of the lesion. If the lesion is in the right eye, the person would tilt the head to his left side, right? So in order to compensate for this extorsion. Why? Because the superior oblique that is responsible for the intorsion is paralyzed. There is extorsion. So in order to compensate that, the person would tilt his head to the opposite side, right? So that is the concept of extortion, intorsion, and the trochlear nerve damage. Fine. Now we would come on to the sixth cranial nerve. What is the sixth cranial nerve? The abducens nerve. So the abducens nerve, it supplies the lateral rectus muscle, right? LR6. Lateral rectus muscle is supplied by the abducens nerve. What is the function of lateral rectus? Abduction of the eye. So from that the name has come, abducens nerve, right? So the abducens nerve, it has got a very long course before it pierces the brain, because before it pierces the dura, around the brainstem there is a very long course, and after it pierces the dura, it enters the cavernous sinus, and it is in direct relation with the internal carotid artery, right? And through the superior orbital fissure, it enters the orbit to supply the lateral rectus muscle. So what happens in case of a lesion of the abducens nerve? There would be the lateral rectus is gone, so you will get a medially directed eye that cannot abduct. Fine. Lateral rectus is responsible for abduction. Since it is gone, you will get a medially directed eye, right? This is a medially directed eye that cannot abduct. So that is the problem with a sixth nerve lesion. Now let us learn another important concept, that is the concept of that is the internuclear ophthalmoplegia, right? So to know that, we should know the concept of horizontal gaze, right? So this person wants to look to his left side, right? So if the person want to look to his left side, what all things are going to happen? Let us see. So the impulses from the right frontal eye field, they reach the left paramedian pontine reticular formation, also called as the PPRF, right? So right frontal eye field, the impulses, they reach the left PPRF. From left PPRF, the impulses would reach the abducens nucleus, right? So the abducens nucleus, it is the sixth nerve nucleus, so that the sixth nerve that supplies the lateral rectus of the left eye, right? The left abducens nucleus is supplying the lateral rectus of the left eye. So once the impulses reach through the sixth cranial nerve, so the lateral rectus is contracted and the left eye is abducted, right? So the left eye is abducted. Now what happens? The abducens nucleus, it is connected with the oculomotor nucleus through a very special pathway, right? This is a very special communication between the oculomotor nucleus of the right side and the abducens nucleus of the left side. This is the right medial longitudinal fasciculus, right? So remember that the right medial longitudinal fasciculus, the right MLF or the right medial longitudinal fasciculus connects the right oculomotor nucleus with the left abducens nucleus, right? So the right oculomotor nucleus is connected with the left abducens nucleus through the right medial longitudinal fasciculus. Remember this, otherwise you will confuse, right? So that is the right medial longitudinal fasciculus. So the impulses would from the abducens nucleus, it would reach the oculomotor nucleus, and the oculomotor nucleus, it would give the supply, it is giving the supply to the medial rectus of the right eye, and this medial rectus will contract, and as a result both the eyes, they move in the same direction to the left, and the person is able to look to the left, right? So this is the concept of horizontal gaze. Once again, right frontal eye field, right left parapomedian pontine reticular formation or left PPR of abducens, left abducens nucleus and left sixth nerve. The left lateral rectus is contracted, the left eye is able to look to the left. Now there is a tract, that is the right medial longitudinal fasciculus connecting the right oculomotor nucleus with the left abducens nucleus. So the impulses from the abducens nucleus reach the oculomotor nucleus through the right medial longitudinal fasciculus in this case, and from the oculomotor nucleus, the medial rectus, it is supplying the medial rectus muscle, right? Oculomotor nerve supplying the medial rectus muscle. So the medial rectus muscle is also contracted simultaneously, so that the medial this eye is adducted and this eye is abducted, right? So the person, both eyes are moving in the same direction, the person is able to look to his left. Fine. So this is the concept of horizontal gaze. Now what happens if there is a lesion in the medial longitudinal fasciculus, right? Here there is a lesion in the medial longitudinal fasciculus. So from the right frontal eye field, again the impulses would reach the PPRF, left PPRF. It would reach the abducens nucleus, and through the sixth nerve it would reach the lateral rectus. The lateral rectus would contract, moving the left eye to the left, right? But what happens? The communication between the abducens nucleus and the oculomotor nucleus is gone, right? It is the right medial longitudinal fasciculus that is damaged. So what happens? The abducens nerve is not able to communicate with the oculomotor nucleus. So what happens? The medial rectus does not function. So the left eye will abduct, but the right eye does not move and it remains in the midline, right? So that is called as internuclear ophthalmoplegia. So this is how the person would look. Okay, the person wants to look to his left side. So the left eye is abducting, but the right eye is remaining in the midline. It is not moving, right? Because the medial rectus is not working. This is due to right medial longitudinal fasciculus lesion, and this is called as the right internuclear ophthalmoplegia, because the right eye is not moving, right? That is why it is called as the right internuclear ophthalmoplegia. There is impaired adduction. Clear? So how will you differentiate this internuclear ophthalmoplegia from a third nerve palsy? Here this eye is not this eye is not able to adduct. It can be due to a third nerve palsy on the right side also, right? So how will you differentiate from that? Convergence is normal, right? In internuclear ophthalmoplegia, the convergence is normal, while in oculomotor palsy, convergence is also gone. Fine. So that is the concept of internuclear ophthalmoplegia, right? So that is about the third, fourth as well as the sixth cranial nerves. Now we will start with the fifth cranial nerve, that is the trigeminal nerve, right? So the trigeminal nerve, it is the largest cranial nerve. It has got mainly a sensory component, with also it has got motor components to the muscles of mastication, right? What are the muscles of mastication? The temporalis, the masseter as well as the pterygoids. So the motor component to the muscles of mastication is by the trigeminal nerve, but it is mainly a sensory nerve, right? So there are three sensory divisions, that is the ophthalmic division, the maxillary division and the mandibular division, right? So this is called as the trigeminal nerve. Three, right? So the ophthalmic division, it supplies the scalp that is anterior to the vertex, right? The scalp that is anterior to the vertex and the forehead as well as the upper part of the side of the nose, right? And the maxillary the region is the involves the malar region as well as the upper lip, right? So that is the maxillary division. Then the mandibular division innervates the chin as well as the ear lobules and all, right? So this is the trigeminal nerve. It has got three nucleus, that is the mesencephalic nucleus that is situated in the midbrain, the chief sensory nucleus in the pons, and the spinal nucleus in the medulla. So see that in the nucleus of the trigeminal nerve is very large, right? So the mesencephalic nucleus that is situated in the midbrain that receives the proprioceptive information from the jaw, right? The proprioceptive information from the jaw is received by the mesencephalic nucleus in the midbrain, and the chief sensory nucleus, it encodes fine touch as well as vibration from the face, right? From the face, the fine touch vibration, it is encoded by the chief sensory nucleus. And the spinal nucleus in the medulla, that is responsible for the pain and temperature from the face, right? Pain and temperature is coded by the spinal nucleus in the medulla. Now there are some important reflexes. What are they? The corneal as well as the conjunctival reflex, right? So both the corneal and the conjunctival reflex, the afferent is the fifth nerve, while the efferent is the facial nerve. Fine. Afferent is the fifth nerve, efferent is the facial nerve. So the corneal and the conjunctival reflex, you have to test it. Also you should elicit the jaw jerk. In case of jaw jerk, both the afferent as well as the efferent is the trigeminal nerve itself. Fine. So now remember that the jaw jerk may be absent even in normal individuals. Fine. So what happens when there is a lesion of the trigeminal nerve or its nucleus? There would be loss of sensation on same side of the face. There would be weakness of the muscles of mastication. Why? The motor supply to the muscles of mastication is by the trigeminal nerve, right? So there will be weakness in mastication or chewing. Fine. And then the deviation, the jaw will be deviated to the affected side. Remember, there is deviation of the jaw to the affected side. Then corneal conjunctival reflexes would be lost. Then jaw jerk reflex, it would be exaggerated when there is a bilateral upper motor neuron lesion above the pons, right? Above the pons, if there is a bilateral upper motor neuron lesion, then the jaw jerk reflex would be exaggerated. Fine. Now another important medical condition that is related with the trigeminal nerve is the trigeminal neuralgia, right? That there is paroxysms of intense pain in the distribution of the fifth cranial nerve that is often triggered by face wash, eating, shaving, etc. And this is usually unilateral and seen in more than 50 years old. Usually give carbamazepine here as a treatment. Surgical decompression is also there. Fine. Now we will come on to the facial nerve, right? Very important nerve, the facial nerve. We are always dealing with the facial nerve, right? So the facial nerve, in fact, it has got three components, that is the parasympathetic component, the motor component, as well as the sensory component, right? So the motor component is that it supplies the muscles of facial expression. Fine. Then it has got the sensory component. Sensory component is it carries sensations from anterior 2/3 of the tongue. Anterior 2/3 of the tongue, the sensation is carried by the facial nerve, right? So also it has got parasympathetic component. Parasympathetic component, it is it supplies secretomotor fibers to the lacrimal gland, the sublingual gland, as well as the submandibular gland. Fine. So three components: motor components to the muscles of facial expression, sensory component that is carries taste sensations from anterior 2/3 of the tongue, that is via the chorda tympani branch, right? Via the chorda tympani branch, it carries the taste sensations. Fine. And parasympathetic supply to the lacrimal gland, the sublingual gland, as well as the submandibular gland. So these are the major function. So what is the course of the facial nerve? The facial nerve, from its motor nucleus that is situated in the lower pons, the fibers will loop back around the abducent nucleus, right? This is the abducent nucleus. So the fibers will loop back around the abducent nucleus, and then this would emerge from the lateral frontomedullary junction, right? So you can see the facial nerve that is emerging from the lateral frontomedullary junction. Now after emerging from the lateral frontomedullary junction, it is going to enter the internal acoustic meatus, right? You can see here the facial nerve, the motor nucleus, it is emerging from the lateral frontomedullary junction and it is entering onto the internal acoustic meatus, and then it continues in the facial canal within the temporal bone, and finally it exits the skull, right? Finally it would exit the skull through the stylomastoid foramen, and after exiting from the stylomastoid foramen, it passes through the parotid gland and it gives off its 5 terminal branches. What are the 5 terminal branches? That is the temporal branch, 2 the zygomatic branch, 3 the buccal branch, 4 the mandibular branch, as well as 5 the cervical branch. So all these muscles which all these branches which innervate the muscles of facial expression. Fine. So now we come to a very important concept, especially in patients with hemiplegia. You have to know these concepts very clearly. Facial palsy, right? A patient who is coming with hemiplegia not only comes with the weakness of the body, but also you would say that about the facial deviation, right? So let us study about the facial palsy. So facial palsy, it can be due to an upper motor neuron lesion or a lower motor neuron lesion, right? So you can see, remember that the upper part of the face, we can divide it into 2, right? The upper part as well as the lower part. The upper part receives bilateral innervation, that is this is the facial nucleus that is situated in the pons, right? This is the upper face division and this is the lower face division. So the upper half, it receives in a bilateral innervation, that is from the contralateral side as well as ipsilateral side. It has got the UMN innervation, that is the corticonuclear fibers from both the sides. It has got a bilateral innervation of the upper face, while in the lower face it has got only the contralateral innervation, right? In the lower face you can see it comes only from the contralateral side, not from the ipsilateral side. So since the upper part of the face receives, so from the upper part you can see, okay, it is receiving bilateral and the nucleus, facial nucleus, okay, and it is coming to supply the upper part of the face, and the fibers these are the fibers that are supplying the lower part of the face from the lower face division, right? So the upper part of the face, it is receiving bilateral innervation and hence it is spared in case of an upper motor neuron lesion, right? So suppose this A lesion, the lesion is at point A. So the upper motor neuron fibers, that is from the contralateral side, is interrupted, right? So what happens in case of the upper face? The ipsilateral side is okay, right? So there would be the upper part of the face would be spared, while the lower half of this face, it receives innervation only from the opposite side, and that opposite side is gone. So what happens? The lower half of the face would be involved, right? So in this patient, the wrinkling would be normal, right? The wrinkling of the forehead would be normal in upper motor neuron lesion, but the lower half is involved, and as a result what will happen? You can see in this diagram, this is the upper motor neuron lesion of the right. So upper motor neuron lesion, so the right side of the face is involved. You can see the right side upper face is preserved, right? The wrinkling is there, wrinkling is normal, while in the lower face there is loss of nasolabial fold and there is deviation of angle of mouth to the normal side. Remember, always very important, the angle of mouth, it deviates to the normal side. Why? Because the normal side, the muscles are intact. Here the muscles are paralyzed, right? So it is going to pull the angle of mouth to the opposite side. Fine. So the angle of mouth, it deviates to the normal side. Fine. So that is the upper motor neuron lesion. Now what happens in case of lower motor neuron lesion? See, this is a lower motor neuron lesion. That is the facial nucleus or the facial nerve is affected. Lower motor neuron facial palsy. What happens in case of a lower motor neuron facial palsy? You can see that the entire half of the face is going to get affected, right? So this is gone, the supply is gone. So entire half of the face is going to get affected on the same side of lesion. On the same side of the lesion, the entire half is going to get affected, right? You can see this is the lower motor neuron lesion. The entire half is affected. There is loss of wrinkling, loss of nasolabial fold, mouth deviates to the normal side. And another important phenomenon is the Bell's phenomenon, right? What is Bell's phenomenon? When the patient attempts to close the eye, you can see the eyeball is rolling upward, right? This is called as Bell's phenomenon. You can see here. The patient is trying to close the eye. You can see the eyeball is moving upward, right? So what is Bell's phenomenon due to? It is due to inability to close the eye. Fine. So that is about the upper motor neuron type of facial palsy and lower motor neuron type of facial palsy, right? So in hemiplegia, you would be getting an upper motor neuron type, and you should remember the upper half of the face would be spared, and you have to ask for the facial deviation also. Usually the patients will, the complaint would be having that also, right? The patient will say he has developed facial deviation. The bystander would be saying the patient has developed facial deviation plus weakness. Fine. So very important to know this concept. Now this is another question which is usually asked by the examiners. What are the common causes of seventh nerve palsy, right? So in case of, so we can divide it into two, that is unilateral as well as bilateral facial nerve palsy. In case of unilateral facial nerve palsy, it can be UMN type and LMN type, lower motor neuron type. So what are the upper motor neuron causes? That include the vascular cause, that is stroke, which we usually see, and cerebral tumors, multiple sclerosis are all the cause for the upper motor neuron type, right? And what about the lower motor neuron type? The Bell's palsy, very important. Bell's palsy can cause unilateral lower motor neuron palsy, a tumor of the parotid gland, right? Because we have seen the relation of the facial nerve with the parotid gland. So parotid tumors, then diabetes, these all can cause LMN type, that is unilateral. Now when there is bilateral facial nerve palsy, so the bilateral upper motor neuron palsy you will get in case of a motor neuron disease, and also in case of multi-infarct dementia. And the lower motor neuron type you get it in cases of Guillain-Barré syndrome, sarcoidosis as well as leprosy. So these are the causes of lower motor neuron, bilateral lower motor neuron type of facial palsy, right? So now you know how to differentiate between the upper motor neuron as well as the lower motor neuron facial palsy. In case of UMN facial palsy, the upper half of the face is spared, right? So the problem is coming when there is bilateral UMN palsy and bilateral LMN palsy. How will you differentiate between a bilateral upper motor neuron palsy and a bilateral lower motor neuron palsy, right? So in case of bilateral upper motor neuron palsy, the Bell's phenomenon would be absent. The emotional fibers are spared. There will be long tract signs, that is the corticospinal tract is also involved. So there will be bilateral long tract signs would be there. Then the jaw jerk would be exaggerated and the corneal reflex would be present. While in case of bilateral lower motor neuron palsy, the Bell's phenomenon is present, right? I have told you about the Bell's phenomenon. Bell's phenomenon is present. The emotional fibers are affected. Long tract signs would be absent. The jaw jerk would be normal, right? It would be exaggerated in case of bilateral upper motor neuron palsy. And the corneal reflex is also going to be absent in case of bilateral lower motor neuron palsy. Fine. So now we come on to the Bell's palsy. Right. So what is Bell's palsy? I have told you it is a cause. It is a element type of lower motor neuron type of facial palsy. Right. Bell's palsy. What is Bell's palsy? It is an acute onset non-suppurative inflammation of the facial nerve in the facial canal above the stylomastoid foramen. Right. So what is the basic pathophysiology behind Bell's palsy? In case of acute Bell's palsy, there is inflammation of the facial nerve with mononuclear cells, that is lymphocytes and monocytes. So it is thought to be due to an infectious or an immune cause. And you know, the herpes simplex virus type 1 DNA was frequently detected in the endoneural fluid as well as the posterior auricular muscle. And this suggests that a reactivation of this virus case of herpes infection, right, there would be reactivation. So the reactivation of this virus in the geniculate ganglion is might be responsible for most of the cases, right. The etiology is not clear-cut clear. So a hypothesis, or since this DNA was frequently detected in the endoneural fluid as well as the posterior auricular muscle, it is suggested that a reactivation of this virus would be the cause for most of the cases, right. So that is the pathophysiology. Now, what are the risk factors? Diabetes, hypertension, and herpes virus infection, that is type 1 infection, are all risk factors. And what are the poor prognostic factors for this? Age more than 60 years, decreased lacrimation, hyperacusis, diabetes, hypertension, as well as total paralysis at the onset, right. All these are poor prognostic factors for a Bell's palsy. Bell's palsy is nothing but a lower motor neuron palsy, right. So what is the treatment that is given for Bell's palsy? Can give artificial tears, as well as the recovery is usually spontaneous in 70 to 80% of the patients. Within about 2 to 12 weeks the patients, they recover. And a course of glucocorticoids can be given, that is prednisone, 60 to 80 milligram of prednisone can be given daily during the first 5 days, and then you can taper the dose over the next 5 days, right. So once you give the course of glucocorticoids, the recovery period would shorten, as well as the functional outcome is also improved, right. And physiotherapy is also given for such patients of Bell's palsy, right. So Bell's palsy may be sometimes kept as a short case. So that is about the facial nerve. Now, that is about the facial nerve, right. So now we will come on to the 8th nerve, that is the vestibulocochlear nerve, right. So what is the function of vestibulocochlear nerve? Hearing as well as balance, vestibular part as well as the cochlear part, right. Hearing as well as balance. And then the lesion would cause a sensory neural hearing loss, and there would be loss of balance as well as nystagmus in case of 8th nerve lesion, right. So that is the 8th nerve. Now we will come on to the 9th nerve, as well as the 9th and the 10th nerve, that is the glossopharyngeal as well as the vagus nerve. So the 9th nerve, that is the glossopharyngeal nerve, right. So the nucleus of both 9th and 10th cranial nerves are in the medulla itself, and the 9th cranial nerve, this is the glossopharyngeal nerve, right. So what are the components of the 9th cranial nerve? It has got a motor supply, right. The motor supply is to the stylopharyngeus muscle, whose function is to elevate the pharynx, right. So that is the motor supply to the stylopharyngeus muscle, whose function is to elevate the pharynx. And then it provides parasympathetic supply to the parotid gland, and it also takes the sensation. The sensory component is nothing but it carries the sensations from the posterior wall of the pharynx, the tonsils, the soft palate, as well as it carries taste sensations from posterior 1/3 of the tongue, right. Anterior 2/3 was carried by the facial nerve, right, the chorda tympani branch, and the posterior 1/3 is carried by the glossopharyngeal nerve, right. So that is the glossopharyngeal nerve. Now about the vagus nerve. Vagus nerve is the 10th cranial nerve. It is the longest cranial nerve. So it has got a motor supply. It supplies all the muscles of the pharynx, larynx and soft palate except the stylopharyngeus muscle, that is being supplied by the glossopharyngeus, right. So except the stylopharyngeus as well as the tensor veli palati. So except these two muscles, all the muscles of the soft palate, pharynx and larynx are supplied by the vagus nerve. The motor supply is through the vagus nerve, right. So another important thing is that it has got parasympathetic supply. You know that the vagus nerve is having extensive parasympathetic supply to the heart, to the gastrointestinal tract, as well as the bronchial tree, right. The parasympathetic supply is very extensive, right, for the vagus nerve. So what does the vagal stimulation cause? Vagal stimulation can cause bradycardia, bronchial constriction, as well as secretion of gastric and pancreatic juices, as well as increased peristalsis. All these are due to vagal stimulation, right. And so that is the parasympathetic innervation. So parasympathetic innervation, the motor supply, as well as the, now we will also the sensations, right? It carries the sensations from the larynx, the laryngopharynx, as well as posterior aspect of the external auditory meatus and the adjacent pinna, that is the ear. Okay, right? So external auditory meatus, the posterior aspect, and the adjacent pinna, is, the sensations are, from there are carried by the vagus nerve, also from the larynx and laryngopharynx, right? So that is the motor supply, sensory supply, as well as the parasympathetic supply of the vagus nerve. Fine. Now, why I am saying this two nerves always together? We often test these nerves, 9th and 10th cranial nerves. We often test both the nerves together, right? So why? Because they together they coordinate the functions of swallowing, phonation, articulation, as well as they carry the sensations from the larynx and pharynx. And also the lesions are together, right? It is very rare to get a unilateral lesion. Usually, it is very difficult to get a isolated lesion of 9th or 10th nerve. Usually it occurs together. 9th and 10th cranial nerves, the lesions, they occur together, right? So we test them together so that they are usually affected together, and when they are affected, they lead to symptoms like dysphagia, that is difficulty in swallowing, dysarthria, there is problem in articulation, right, of speech, there will be slurring of speech, and there would be nasal regurgitation of fluids, that is when the patient is taking fluids or liquid food, that would come through the nose, that is nasal regurgitation of fluids. And if the patient is trying to take solid food, he will vomit, right? So that is nasal regurgitation of fluids. And hoarseness of voice would be there. Why? Larynx is being supplied, right? So hoarseness of voice, dysphagia, dysarthria, nasal regurgitation of fluids, all these are due to the lesions of the glossopharyngeal and vagus nerve, right? So now how will we test these nerves? I have told you both these nerves are tested together, right? So you can see, so in order to test these muscles, you have to look for the position of the uvula, right? Usually the position of the uvula is central. So you can see in this diagram, you have to look for the position of the uvula. Usually the position of the uvula is central, right? And you have to look for the symmetry of the palatal arches, right? If the palatal arches are symmetric, see here, you can see both the palatal arches are symmetric, right? So in case of unilateral 10th nerve lesions, right? Unilateral vagus nerve lesions, what happens? The palatal arch on the affected side would be at a lower level compared to the normal side. It would be at a lower level on the affected side. And what happens to the uvula? The uvula is pulled towards the normal side or the healthy side, right? So in case of a unilateral 10th nerve lesion, the palatal arch would be at a lower level and the uvula would be pulled to the healthy side. Fine. So another important reflex is the gag reflex, which you have to check for the 9th and 10th cranial nerve. Why? The afferent of the gag reflex is through the glossopharyngeal nerve, while the efferent is through the vagus nerve, right? So how will you do the gag reflex? You have to touch the posterior pharyngeal wall, right? Posterior pharyngeal wall is, you have to touch the posterior pharyngeal wall with a cotton tipped stick, right? With a cotton tipped stick you have to touch the posterior pharyngeal wall. So what is the observation? You would get elevation and contraction of the pharyngeal musculature, that is accompanied by the retraction of the tongue, right? So this gag reflex would be reduced or absent in case of a lower motor neuron lesion, while this is exaggerated in case of an upper motor neuron lesion. Fine. So that is about the glossopharyngeal and the vagus nerve, right? Just imagine that the glossopharyngeal and vagus nerve are supplying all over here, right? That is the pharynx, the larynx, right? The palate, all are being supplied by the 9th and the 10th cranial nerves. So right now we will come on to the 11th cranial nerve, right? So 11th cranial nerve, it is also called as the spinal accessory nerve, right? So it has got two parts, that is, one is the cranial part, the other is the spinal part, right? The cranial part and the spinal part, right? So the cranial part, it comes from the medulla, while the spinal part, it arises from the lateral column of the spinal cord, and then it enters the foramen magnum, and then it joins with the cranial part, right? So cranial part, then it joins with the cranial part, and then it emerges through the jugular foramen. This is the jugular foramen, right? It is emerging through the jugular foramen, and then it supplies the two important muscles, that is the trapezius muscle as well as the sternocleidomastoid muscle, right? So what is the action of trapezius muscle? Trapezius muscle helps the person to shrug the shoulder, right? So shrug the shoulder, as well as what is the function of sternocleidomastoid? It helps the person to look to the turn the head to the opposite side, right? So how will you test? Ask the patient to shrug the shoulder, apply resistance against it, right? And you can check for the power of the trapezius muscle. And in case of sternocleidomastoid muscle, you are testing. See, if you are asking the person to, so you have to ask the person to look to his right. When you are asking the person to look to his right and applying resistance against it, you are testing the left sternocleidomastoid. Remember that. So it is the left sternocleidomastoid that helps the person to look to the right, and it is the right sternocleidomastoid that helps the person to look to the left, right? So you have to ask the patient. So you have to test both the actions of both the sternocleidomastoids, right? And simultaneously also we can test it. How can you test it? That is by asking the patient to flex the neck against resistance, right? You have to apply resistance and ask the patient to flex the neck. So by that you can test both the sternocleidomastoid. So remember always, the right sternocleidomastoid helps the person to look to the left side, fine, and vice versa. So what happens if there is a lesion? There will be difficulty in shrugging the shoulder, as well as there will be difficulty in turning the chin towards the opposite side, fine. So that is the 11th cranial nerve, that is the spinal accessory nerve. Now we will come on to the 12th cranial nerve, that is the hypoglossal nerve. So what is the function of hypoglossal nerve? The only function of hypoglossal nerve is to provide motor innervation to the muscles of the tongue, and this is controlled by the hypoglossal nucleus that is present in the medulla, right? So you can see in this diagram, you can see, okay, the upper motor neuron, this is the upper motor neuron, this is the lower motor neuron, right? So if there is a lesion, a lower motor neuron lesion, what happens? Or an upper motor neuron lesion of the opposite side, right? What happens in case of an upper motor neuron or lower motor neuron lesion? You ask the patient to protrude the tongue outside. If you ask the patient to protrude the tongue outside, then the tongue would deviate to the affected side, fine. So the tongue is going to deviate to the affected side in case of both upper motor neuron lesion as well as lower motor neuron lesion on protruding the tongue. Remember, you have to underline those words, on protrusion of the tongue. The tongue is going to deviate to the affected side in case of both upper motor neuron as well as lower motor neuron lesions, right? So how will you differentiate between a unilateral lower motor neuron lesion and a unilateral upper motor neuron lesion? In case of a lower motor neuron lesion, you ask the patient to open the mouth, not to protrude. Okay, once the tongue is inside the mouth, it will deviate to the normal side, and on protrusion, this deviates to the affected side. So that is a unilateral LMN lesion. Now what about a upper motor neuron lesion? Inside the mouth, the tongue would be in the midline, and on protrusion, the tongue would deviate to the affected side, right? So on protrusion, let it be UMN, let it be LMN, the tongue would be deviating to the affected side. Clear? So you can know that the hypoglossal nerve is involved there. So now let us know two important terms. What is bulbar palsy? What is pseudobulbar palsy? Right? So bulbar palsy refers to lower motor neuron paralysis of 9th, 10th, 11th and 12th cranial nerves, which are arising from the medulla. See, the medulla is called as the bulb, right? So bulbar palsy refers to the lower motor neuron paralysis of the cranial nerves that arises from the medulla, that is the 9th, 10th, 11th and the 12th cranial nerves, right? While pseudobulbar palsy refers to bilateral upper motor neurons of 9th, 10th, 11th and 12th cranial nerves that occur above the medulla, right? So that is occurring in case of so pseudobulbar palsy is an upper motor neuron lesion that is occurring above the medulla, So that is the difference between bulbar palsy as well as the pseudobulbar palsy, right? So lower bulbar palsy is a lower motor neuron lesion, this is upper motor neuron lesion. Then dysphagia, dysarthria, 9, 10, 11, 12 are involved, right? So dysphagia, dysarthria, dysphonia, nasal regurgitation of fluids are common to both bulbar as well as pseudobulbar palsy. But there are some differences, in case of a bulbar palsy, since it is a lower motor neuron lesion, there would be weakness of the tongue, there would be wasting as well as fasciculations would be there, right? The tongue would be wasted as well as you can see fasciculations of the tongue, right? See in this diagram you can see the tongue is wasted and there would be fasciculations also, fine. So wasting and fasciculation would be there. While in pseudobulbar palsy, the tongue is spastic and it is slow moving, right? And if you elicit the jaw jerk, it would be absent in case of a bulbar palsy, while in pseudobulbar palsy, the jaw jerk would be brisk, fine. And emotional lability, that is absent in case of bulbar palsy, that may be present in case of pseudobulbar palsy. What is emotional lability? It is nothing but, it is the emotional outburst of the patient, right, in the form of unprovoked and uncontrollable laughter or crying, right? There would be you are not provoking the patient, right? Unprovoked as well as that would be uncontrollable also, right? Uncontrollable laughter or crying, that is called as emotional lability, that may be present in case of pseudobulbar palsy, right? So what are the causes of bulbar and pseudobulbar palsy, right? So in case of pseudobulbar palsy, there are no genetic cause, but bulbar palsy, Kennedy's disease, right? It is a X-linked bulbospinal neuronopathy. So that is Kennedy's disease. And vascular causes of pseudobulbar palsy, it is bilateral UMN lesion, right? So that is bilateral hemisphere infarction can cause pseudobulbar palsy. And if the medulla is infarction of the medulla, right, it can lead to bulbar palsy. Then degenerative conditions, that is motor neuron disease, both motor neuron disease can cause both pseudobulbar palsy as well as bulbar palsy. Then what are the infective or inflammatory causes of pseudobulbar palsy? Include multiple sclerosis as well as cerebral vasculitis. And bulbar palsy, myasthenia, Guillain-Barré syndrome, poliomyelitis, Lyme's disease as well as vasculitis, right? And neoplastic, the high brainstem tumors would cause a pseudobulbar palsy, while brainstem glioma as well as malignant meningitis can cause bulbar palsy, right? So these are the common causes. So that is about the 12th cranial nerve. Fine. So we have discussed from 1 to 12 all the cranial nerves in detail. Now I have told you about several deviations, right? The jaw, once the trigeminal nerve is affected, the jaw is deviated, facial nerve affected, face, angle of mouth is deviated, hypoglossal nerve, tongue is deviated, vagus nerve, uvula is deviated, right? So sometimes, in the word you might forget which would be deviated to what side, right? So to remember that, there is a mnemonic for that. 5 plus 12 is equal to 17 and 7 plus 10 is equal to 17, right? The sum comes to be 17, right? So 5th nerve and 12th nerve, that is the trigeminal nerve where the jaw is affected, and the 12th nerve, that is the tongue is deviated, right? So both deviation would be to the affected side. Remember that both jaw and tongue deviation would be to the affected side, while the facial deviation as well as uvula deviation, the face is pulled to the normal side, the uvula is pulled to the normal side. Both facial as well as uvula deviation is to the normal side. That is 7th facial nerve, 10th uvula is due to vagus nerve palsy, right? Deviation. So 10th is 17, right? 7 plus 10, both the sum of both these are 17, right? 5 plus 12 is 17 and 7 plus 10 is 17, right? So always remember the jaw deviation, tongue deviation to the affected side, the face deviation as well as the uvula deviation to the normal side. Fine. So this was in fact a long video. We have discussed about the stroke, the type of strokes, the blood supply of the brain, both the anterior and the posterior circulation, and what are the clinical features of anterior circulation strokes. And then we started with the cranial nerves, the olfactory nerve, 1 to 12 cranial nerves, the olfactory nerve, the optic nerve, the 3rd cranial nerve is the oculomotor nerve, 4th trochlear, 5th trigeminal, 6th abducens, 7th facial nerve, 8th vestibulocochlear nerve, 9th glossopharyngeal, 10th vagus, 11th spinal accessory, and 12th hypoglossal nerve, right? So all the 12 cranial nerves we have discussed. What are the clinical features if there is a lesion of those cranial nerves? Now this information, this idea would help us in our next video when we are discussing about the posterior circulation strokes, right? So I hope you have enjoyed this video. Please do share the video if you have been benefited from this, and also please comment in the comment box below. So thank you and see you in the next video.